Darren's work is the topic of proprioceptive control in injury prevention and treatment. And it's quite refreshing to hear that some of the concepts that I'm going to cover, Darren's also kind of covered. So we're on the same kind of track, which is good news. So I've got 10 minutes to kind of cover elements of proprioception. So we'll see what we can kind of look at in terms of this element, which is just one element of effective rehab. Okay. So can anyone tell me what this is? Yes, yeah, great. So it's the homunculus, which is the kind of a cortical representation of the human body within the brain. And we all have it. It's split into two parts. There's a sensory component and the motor component. And some individuals will have different size representations of different areas. So a pianist, for example, might have kind of a stronger representation of the hands. Someone, a footballer, might have a stronger representation of the feet. So wherever they kind of have a wider representation for their task, their work, their sport, will have a wider representation in the homunculus. Okay? And the great thing about the homunculus and the kind of the neural elements of things is that neuroplasticity that is amenable to training and rehab. And that's so important when we're kind of designing our rehabs, that we do kind of challenge the nervous system sufficiently to optimally emphasise those areas that they need emphasised for their particular sport. Okay? There's a saying that neurons that fire together wire together. So if we can kind of increase that ability of the neural system to work at a greater challenging level, then the greater those kind of networks will be for the chosen sport. Okay. So sensory motor control. Well-adapted motor actions require input from which sensory systems do we rely on, do we feel? Anyone want to hazard a guess as to what sensory systems we might use for sensory motor control? You're using one of them now to look at the slide. Yeah, your eyes. Yeah, any others? We'll go through it. We've got our eyes, haven't we? We've got our inner ear, so our vestibular system as well. Yeah, it's one that's often forgotten. Our skin as well, so our kind of tactile elements, and also our kind of proprioceptors within the muscle tendon units, so our kind of muscle spindles or Golgi tendon organs that are play an important role as well. Okay. So a definition would be that sensory information supplied by specialised nerve endings termed mechanoreceptors. Another question, where may we find mechanoreceptors in the body?
Joints, muscles, tendons.
Yes, yeah, joints, muscles and tendons, so they're kind of key areas. We've also got them in the skin as well. So we've got them in the joints, in the joint capsules, within the muscle spindles, within the fascia, the fascial tissues of the body, and also within the skin as well. So these are our, if we're going to aim to increase proprioception, these are our target areas, if you like, where we know these mechanoreceptors exist. Okay. So we can assess proprioception. So we've got specific tests and we've got non-specific tests. Now most of us will kind of think of proprioceptive testing as how long can you stand on one leg and make it harder with your eyes closed. But there are ways we can kind of be a little bit more specific, because that will kind of assess different elements of the system. So it'll be an element of the kind of vestibular system, the eyes, tactile in terms of the contact of the foot with the floor, and the mechanoreceptors. But we can use things like the joint positional sense. Now a lot of the special tests are most frequently used with cervical rehabilitation, where there's an abundant amount of mechanoreceptors, and certainly the upper cervical spine, linked very closely with the eyes and the vestibular system. So as part of rehab and testing, we can have I sometimes use a laser pen on a kind of a headband or a cap. So I'll kind of draw a little kind of piece of paper on a wall with a circle, and have a laser on the hat which directly hits the circle. I'll ask them to track away to the right, so the laser pen moves across the wall, and I want them to come back and stop till the lasers bang in the middle of the circle. Now they do that with their eyes closed, and that aims to kind of, for me, gives me an indication of how accurately their mechanoreceptors are working within the upper and mid-cervical spine for rotation and accuracy ability there. Another one might be kinesthesia, so that testing of the ability to sense the movement of a limb in space. So to do that, I'll passively move one limb in different directions and different movements, and ask them to replicate that exact movement on the other side with their eyes closed. So you're taking away one element of sensory input and getting them to focus in on the movement on their passively moved side to replicate it actively on their other side. And that might be upper limb or lower limb, it might be focused to wrist, elbow or shoulder, or whatever area you're focusing on. It just gets the brain engaged a little bit more with the rehab process. Force sensor, that ability of the, certainly for muscle spindles to judge the amount of force required for a task, and that can be assessed and trained as well. So it might be that we kind of get them doing a one leg press to a set weight on one leg and trying to kind of replicate that on the other leg and judge when there's a difference. And also using these kind of pressure biofeedback units to try and replicate the amount of pressure from consecutive attempts when looking at upper cervical flexion elements. So a lot of the specific tests are more biased towards cervical, but there are ways we can look at other joints as well. So what could cause altered proprioception? So pain, effusion, trauma and fatigue are the kind of key elements, and with a sporting environment, chances are they're going to get pain, they might get effusion if they have an acute injury, they may get an impact injury that doesn't maybe stop them playing, but might be sufficient to alter their mechanoreceptors and their feedback that can affect proprioception. And fatigue, so a lot of us that do kind of work high intensity training or finish a long run or a heavy session, sometimes have that feeling that we're slightly uncoordinated and can't quite get our feet right, can't quite focus on fine motor tasks, and that's because the proprioception has been affected. So consequences, so one of the main consequences is that kind of feeling of unsteadiness, clumsiness, lack of coordination, which naturally, if that's towards the end of a game, might be one factor that explains why we see an increased incidence of injury at the end of the first half and at the end of the second half of a match, because there might be less proprioceptive drive for the brain to focus where the body's in space. Long term, it might be we have deficiency in the muscular protection of tissues, maybe an increased risk of injury, maybe an increased incidence of secondary OA if we're not controlling the movement around a particular joint, and perhaps altered muscle performance. But the increased risk of injury is the key one. So how do we improve proprioception? It would make sense really to focus on the areas that we know might alter proprioception. So if we look at pain, it might be appropriate analgesics to settle the pain early post-injury. If we've got an effusion, we want to reduce that effusion by whatever means we can, as soon as possible. If it's an agility issue, we want to include elements of agility training, certainly as prehab, as preventative strategies, but post-injury as well. And strength and endurance as well, often an area where, certainly for agility type sports, an area that's maybe not as focused on as it maybe should be, to make that athlete a little bit more robust for the sport that they do. So how can we kind of stimulate the mechanoreceptors in the joints, soft tissues and skin via other methods other than maybe exercise? So we might use hands-on therapies to augment that sensory input. That might be manipulation, mobilization, massage, whatever elements you want to use. We might use strapping and taping. So a lot of uses for K-tape. One of them might be just to augment the sensory input. And from an ankle prophylactic perspective, that may be one area where we might be using taping around ankle injuries to maybe prevent injury, maximising the proprioceptive drive through the tactile elements of the skin. And another one which probably has more evidence in terms of prophylactic ankle sprains is the brace, which a lot of tennis players and basketball guys use as well. So, elements that we could use in terms of exercise to improve proprioception, we might look at joint positioning training. So if we look at some of the main areas where we might have injury, so ankle where we might be more prone to those positions of the joint between 9 and 22 degrees, so that landing from a jump with slightly plant flexed ankle, can we train that joint positional sense in that maybe vulnerable zone? Around the knee, most injuries occur between 10 and 60 degrees. Can we train the knee and proprioception in those ranges? Typically we train proprioception with a straight knee on a wobble board. Can we kind of, by flexing the knee, maybe mirror a little bit more closely the kind of positions the knee will be in when vulnerable to injury? And the same with shoulder. In those positions of external rotation, we might get more bang for your buck doing the training in those areas. Force sense training, so in terms of cervical spine rehab, there may be a role for a little bit more of these Chattanooga pressure biofeedback units. You train the deep cervical neck flexors. And coordination training, so increasingly now, certainly in team sports, we're looking at this variety of training to try and increase agility that's kind of cognitive rich for the athlete to do as well, so it engages the brain, and like as Darren suggested earlier, it's just something different for their kind of motor system, their sensory system to focus on, just to kind of really sharpen up those neural pathways. The typical balance training, whether it's upper limb using gym balls or the Bosu balls or wobble discs, for the lower limb, commonly use a regime. Plyometric training, again, just a different form of exercise to stimulate the brain and the joints at the same time, using that stretch shortening cycle principle. And the vibration training, which is probably kind of going out of fashion now. When it kind of first arrived in gyms maybe 10 years ago, people were sitting on them to try and let the fat off the bum go, or lying on the tummy on them to get rid of the belly. Not an appropriate use, but maybe there is some evidence that can stimulate an extra degree of proprioceptive drive through using the vibration plates like this. So if they are available, that might be one option to look at. So in terms of final thoughts, and this probably sums up Darren's kind of presentation as well, we maybe need to kind of look at, so from those of us coming at it from a rehab perspective, just kind of making our exercises and our rehab that little bit more cognitive rich, rather than sending people away with maybe quite simple, boring exercises that don't really engage the brain too much, just to try and engage the brain as well as the body system that we're targeting, to try and strengthen those networks and those neural connections to get better, longer lasting results, and maybe have an important role in injury prevention.